And today we have a presentation from our Health Equity Institute, Michelle Wilson and Adeline Bailey. The floor is yours. Please let us know what the great work that you guys do.
Sure, thank you, Jen. So, one of the things that we like to do is we like to know who is in the room. So we usually start off our presentations with, a round of introductions, and certainly welcome all, if you can, to turn on your video so that we can see your lovely faces and have a nice two-way conversation. So I am Michelle Wilson. I am one of the co-directors for RIDOH's Health Equity Institute. I've been at the Department of Health for 13 years. It'll be 13 years in August. And in addition to my role within the Health Equity Institute, I've also served for 6 years with the Center for Emergency Preparedness and Response, and then came into RIDOH working on a CDC grant with the Tobacco Control Program to try to implement policies within the city of Providence that would reduce access to tobacco products among youth. So that has been my journey at RIDOH. Thank you, and thank you all for joining this morning. Certainly welcome any questions that you may have, and look forward to meeting you all and finding out what you're doing at RIDOH.
My name is Adeline Bailey. I am the program manager for the Refugee Health Program, and I'm also serve as the lead point person for the class training, which is the culturally linguistically appropriate services. I've been with RIDOH for about 1.5 years, working in the COVID response team prior to this position, and then I transitioned to this position this year and been able to work with the refugee health community. Jen, I'm unable to share. Do you think you can give me access to that to be able to pull up the presentation?
Yeah, let me take a look.
These only meeting organizers.
All right, you want to try one more time?
Yeah, it's still not letting me. The button is unavailable right now. I'm not sure if it's maybe because it's recording.
All right, hold on one second. Okay, I see the issue. All right, should be all set now.
Perfect. Thank you so much.
You're welcome. I can introduce myself, and then we can have some of the other people on the call introduce themselves as well. My name is Jen Ritchie. I am the program manager for the internship program, which we refer to as a Scholar Public Health program. I also worked in COVID for probably 2 years. I had only done 5 months in my position, and then COVID happened. So this is kind of my first time going through everything, even though I've been with the department for over 3 years. So I was also in that crazy boat of COVID and then getting transitioned back. So I'm excited to hear from you guys today. Is there anyone on the call who would like to introduce themselves that is able to turn on the camera?
Sure, I can, Jen. Hi, Jen. Hi, Michelle.
Hi.
Hi, Ireland. Nice to meet you. I finally had my first contact with you last week. I'm Jill DiRico. I am at the State Office of Rural Health, Office of Primary Care, and was reallocated to COVID in March of 2020, where I still am. I do a lot of class training with the medical providers that are on a J1 visa for the state. Those are foreign-born physicians who are practicing here. And I think that's about it. If you have any questions about the State Office of Rural Health or the Primary Care Office or anything like that, please always feel free to reach out. I might be a little delayed in responding, but I absolutely will, and I'm looking forward to meeting everyone.
So
I can go. My camera, for some reason, won't actually turn on, but I'm Sophie. I use she, her pronouns. And I'm actually interning with the refugee health program this summer. So Adeline and Michelle are two people that I work with on the daily, and they are wonderful. So I'm really excited for everyone else to get to hear about the work that they're doing.
Great, thank you.
Hey everybody, I'm Madison. I'm the new adolescent and school health coordinator. Prior to this role, I was doing community health work with one of our state's CAP agencies. So the link was sent to me, and I'm just trying to learn about everything going on at RIDOH.
Great, thank you. And then Judith and Megan, I don't know if either one of you are. Oh, yep.
Hi, I'm Judith Han. I am a contractor working with the Center for Emergency Preparedness and Response. I have been there since February.
Woo woo! Shout out to CPR. All right.
Be careful. I started at CPR as a summer intern, and that was 10 years ago.
Oh my goodness.
CPR alum on the call.
There's a lot going on always.
Nice. And
All right, I think that is it.
okay. All right. Next slide.
Everyone can see the slides?
Yeah, and Adeline, if you want to go into presentation mode, cool. All right, so hopefully during this section, some of the objectives are to help you better understand RIDOH's visions and goals, and how we're advancing health equity, not just within the Health Equity Institute, but across the department as a whole. Develop a deeper understanding of what inequity looks like and sort of some of the historical roots as to how we have gotten here. They say in order to understand the present, you have to look to the past. So hoping the information that we share with you today will help give you some understanding of that. And then to recognize some of the strategies that we are using within HEI and across RIDOH to help advance health equity in the work that we do. Next slide. So we're just going to give you sort of an overview of the Health Equity Institute. And, as I said, I am one of two co-directors, and there's a body of work that I represent. And then I believe that there's a future presentation about the health equity zones. And so I'm not going to go into that too much, but that is, health equity zones are a part of HEI, the acronym that we use for Health Equity Institute. But I'm just going to give you an overview of the work that, both Adeline and I is pretty much what we own. Next slide. So I will turn it over to Adeline and she can dive into what she does within HEI.
Thank you, Michelle. So the Refugee Health Program is nestled within the Health Equity Institute. It's part of our responsibility. We're working the program to do three categories. Under the Refugee Health Promotion, we coordinate care by working with refugee resettlement agencies, state programs, and other health and social services to develop and coordinate comprehensive health services and support the refugees. This includes any type of needs that are in the community at the time. So as like the summer, we've been working on some oral health programs with the community and trying to get some providers together for that. We also assist refugees in meeting the medical screening requirements that are needed when they arrive here, and also to adjust their status to become permanent residents. We convene partners to identify and resolve systems of barriers to appropriate care for refugees. We provide an opportunity for fundings through mini grants and to voluntary agencies and resettlement agencies to promote other refugee health initiatives and programs within the community. We also perform surveillance and refugee health of the refugee health information and for planning and reporting purposes along with our federal partners. And lastly, we also provide training to providers to engage in culturally and linguistically appropriate services. This includes both our refugee providers as well as any other providers within the community that will be working with refugees or even other immigrant or migrant communities. Through the Refugee Cash and Medical Assistance Program, we actually respond to the unique healthcare needs for refugees, asylees, and humanitarian parolees. And this is making sure that they are provided the necessary care when they arrive here to Rhode Island. And as mentioned prior, part of the work that we do is training people to be culturally and linguistically appropriate services, and this includes making them aware and knowledgeable about the national class standards and the requirement that comes with that mandate.
Thank you, Adeline. So in addition to all of the great work that's happening within our refugee health program and with our class training, also the Office of Minority Health sits within the Health Equity Institute. So OMH, we don't have any active programming going on currently. We recently completed 2 CDC grants that we had that were focused on youth mentoring. So providing supports to middle and high school aged young men, middle school aged girls, to make sure that they had the academic supports, the social supports, and the behavioral supports to ensure their academic success in school. But the OMH actively participates in regional meetings as well as national meetings regarding issues surrounding minority health. As I mentioned, we also have our health equity zones, and I know that there's a future presentation on the HESs, but there are about 15 health equity zones currently, doing a lot of great work in the community, really supporting them and enabling them to identify health needs and other social determinant of health needs that they identify within their geographic areas, and then providing supports to those health equity zones to be able to address and tackle those issues, not just from a programmatic perspective, but also from a policy perspective. And lots of great work going on with our HESs. And you can go to the website and learn more about the health equity zones. And again, you'll be hearing more information about those. And then, as Jen had mentioned, many of us, including Jill and others on the phone, got absorbed by the COVID-19 response for the past 2 years, 2.5 years. The response is sort of still underway, certainly not as grand as it has been in the past, but many of us still have sort of one leg in the response world as well. And so the COVID-19 equity response was some folks within HEI who were working with the various work streams across state agencies to make sure that the response and resources and recovery were really inclusive of meeting the needs of those communities that were most impacted by the pandemic. So we identified 16 zip code areas, which we called high density communities, and they were broken down into 2 tiers. Tier 1 were those communities that really were adversely impacted by the pandemic. We saw high rates of transmission and low rates of vaccination. And then we had our Tier 2 communities where we were monitoring, meeting the rates of transmission and vaccination sort of ebbed and flowed. It went up and down. And so we are still working closely with many of those communities because even though the response phase of this pandemic may be winding down, we also know that during recovery, there are certain communities that do not recover as quickly as others, and we want to make sure that those communities are still, we have our eye on those communities, and we're still making sure that those communities are getting the resources they need to be able to recover. Next slide. So we're just going to spend a little bit of time talking about health equity. It's a term that seems to be popping up everywhere, and just want to have a discussion about what it looks like within RIDOH and the different issues that we are tackling when we talk about health equity. Next slide. So just to give a definition that we use at RIDOH, so health equity requires developing strategies to improve health based on the unique circumstances of people and places affected. So, you know, when we talked a little bit about our health equity zones, a perfect example of how within each of those health equity zones, there's a collaborative of organizations coming together and working to develop strategies to be able to improve health outcomes of the people living in those communities. And when we talk about health equity, we're addressing issues such as poverty, really looking at some of the root causes of health inequities, such as racism, and then a host of other factors that are included. So education and housing, and what does the built environment, or what does the community look like where people live, that is also either contributing positively or negatively to their health outcomes. Next slide. So this is a graphic that we use often to help folks understand what we mean when we talk about equity, because there are times when equity and equality are sometimes used synonymously, but they're not the same thing. And so if you look at the first graphic, this is sort of the reality of the world that we have lived in historically, and in some cases even now, where we know that there are certain communities that have tremendous advantage, and then there are those that they're just trying to get, you know, to ground level to be able to take advantage of the opportunities that are out there. And sort of this first visual is the world that we live in within the Health Equity Institute. But as we continue to drive for change, you know, we want to make sure that, you know, we get to that place of liberation where there are no barriers and where everyone has the resources that they need in order to live healthy lives. And sort of in between this reality and this place of liberation, you know, there for many years, you know, 60s, 70s, 80s, there was this push for equality, which was great. But when we talk about equality, we're not necessarily giving everyone the resources that they need. We're treating people equally without taking into consideration, you know, individually what's happening within their own communities or what's happening within their own lives. So in this picture here, even though we've given each of these individuals the same size box, they all can't see over the fence. And so this is a great way of helping to understand that not everybody needs the same thing. We really have to get to understand what people's needs are in order to help them be successful. When we get to a place of equity, that's when we're taking into consideration what the needs of different communities are, what the needs of individuals are. And in this third picture, you can see that because we've taken into consideration this concept of equity, now all three of these individuals can see over the fence. However, the issue is the barrier in this is the fence. We want to be able to remove the fence so that there will be no need for, you know, all of these boxes and all of these adjustments, and getting to that place of liberty where there are no barriers and that everyone can be successful and, you know, have access to what it is they need to live healthy lives. So I hope that this picture is sort of helping you understand sort of this trajectory of where we are in the different places that we work and the things that we need to adjust in order to build healthy communities. Next slide. So there are a variety of health narratives that's also kind of go along with how we are tackling equity. And some of these may sound familiar to you because they still, in many ways, are informing how we address healthcare, about how we address the health of individuals. And so this dominant health narrative places the health outcomes specifically on you and I and the choices that we make. And the choices that we make as individuals determines our health outcomes. And so things that are often discussed are, well, you know, you have good genes, you have bad genes, you got these DNA from your mother, and therefore you're going to have, you know, specific chronic illnesses. And that's not to say that that's not true, but that is not the dominant reason why we're seeing health outcomes and health disparities in some of our communities. I know we've also heard the food choices that we make. You know, if you have a poor diet and you eat unhealthy food, you know, that is going to contribute to, you know, poor health outcomes. Yes, it does. but that is not the sole reason why we are seeing, from a community population perspective, disparate health outcomes in some of our communities. And then, the amount of exercise, we all have to join a gym, go get that gym membership. And there's a lot of, especially around, the first of the year, gyms are promoting memberships like crazy. And so that's not to say that this is bad messaging, because it's not, because these do play a role in the outcome of an individual. But when we're talking about population health, community health, there are other factors that contribute to this far more so than what we're seeing here. But oftentimes this is the dominant health narrative that we hear. It's a lot of messaging that you hear from healthcare providers. When you're watching television, the narrative is the individual has to take care of, we have to take care of ourselves. And it doesn't take into account, some of those broader factors. Next screen. So then the question becomes, where does health happen? And so, CDC tells us that 80% of health happens in community, and that 20% of health outcomes are due to those genetic factors or those clinical factors. So on that previous slide, 20% of that is attributed to health outcomes. The other 80% happens outside of that sort of individual sphere. And so if we look at the circle here, social and economic factors account for 40% of health outcomes. Your genes and your biology, that good DNA, that bad DNA, whatever you want to call it, accounts for 10%. The physical environment where one lives accounts for 10%. So when we talk about the physical environment, does your community have safe parks? Does your community have safe streets? And what I mean by safe streets is, can you walk on the sidewalk? Are the sidewalks all broken up? Do you have street lights in your community that actually work? Like, what does the physical footprint of your community look like, so that folks can go out, and if they want to get exercise or walk in that community, they're able to do so? Are there stores that, healthy stores in the community, or do you have a lot of stores that just sell junk food? So a lot of that is taken into consideration. Clinical care is 10%, and then health behaviors account for 30%. So I think clearly that we can see that, the health happens not just based on the choices that you make about what you want to do, but also a lot happens, is determined by the communities where one lives, or one zip code. And then we have the emerging health narrative, which really takes into account that 80% that we just talked about, and what comprises that 80%. And those are what we call the social determinants of health. So as you can see on this graphic here, we have those individual factors, which account for your age and genetics, and individual behaviors. And so when we talked about the dominant health narrative, we talked about diet and exercise and, things that you're doing to stay healthy. But we also have to take into consideration the other 80%, as I said. So, what are those services, and what is the living conditions where people live? Do you have, in your community, is there safe housing? What does the soil look like in your community? Can you grow a garden, or is your soil contaminated with lead, for example? What kind of access do you have to services or to grocery stores in your community? Are there parks? Do you have access to transportation? Are there good schools? The folks living in those communities, do they have access to good jobs where they can have, sick paid leave and other kinds of benefits? And then even if they do have benefits, what do those benefits look like? All of that is important. And then even beyond just those other sort of social determinants, we also have to look at the political determinants of health, because that also, impacts the health of a community. So are the people living in that community civically engaged? Do they have good representation in leadership? Are the folks that they are electing to represent those communities, either at a municipal level or at the state level, are they fighting to make sure that those communities have the resources they need to be healthy? What does the citizenship of the community look like? Is it a community that's predominantly immigrant or refugee, or, so all of those things we have to take into consideration. And then also social cohesion. I think we can all agree that, you hear your stories, your parents tell stories about back in the day, everyone in the community knew one another. You knew who lived next door, and, you would go out into the community and folks would speak to one another, and folks were very neighborly. I think now those that can exist in pockets of the community, but I think in general, our communities are not as cohesive as they used to be historically, and we need to get back to, really knowing who our neighbors are, who lives on our streets, so that if there is some kind of event or disaster, that, down the street you have an elderly person that's 80 years old and you might want to go check on them. Up the street you may have a family, with a mother and father with, lots of kids, and they may need some supports as well. But oftentimes, folks aren't aware of who's living in their communities, and we really need to get back to that social cohesion. Next slide. So again, we just talked a little bit about the emerging health narrative and, the importance of the social determinants of health. And these are the conditions and the places where people live, learn, play, and work that affect a wide range of health and quality of life risks and outcomes. And again, we sort of went through, healthcare, education, what's the economic stability of the community, what is the built environment, what does the neighborhood look like, and what are those social and community factors that are holding that community together, and or that need to be addressed to be able to bring that cohesion that we talked about. How do we work on making our communities more socially cohesive? Next slide. And then, as we do our work within the Health Equity Institute and across RIDOH, historically, we talk about being upstream or downstream. And so when we talk about being downstream, that's really when we're, if you think about sort of the programmatic work that we do at RIDOH, those are kind of downstream solutions to addressing some of these problems. But we know that programs in and of themselves are limited in their impact. And we want to really get to the root of what's driving some of these disparities in our communities. And so ways that we can address the social determinants of health and have a greater impact is if we move upstream, where we start tackling some of the laws and the policies and the regulations that have created these conditions in the communities that show up. So, how do we look at housing policy? How do we look at food policy, transportation policy? How do we change our criminal justice system, immigration policy, and a host of other policies that we know are being made at the municipal level, at the state level, and at the federal level that historically have driven some of the poor health outcomes, or are responsible for the poor health outcomes in our communities? And how do we begin to try to change those policies and those laws so that they have a better impact on improving community conditions? And then, other factors that we also take into consideration in our work is this concept of intersectionality. So in addition to sort of the narratives, the dominant narrative, the emerging narrative, that we also have to be aware of and take into consideration when we're doing our work. We also have to look at intersectionality and how the various dimensions of who we are also impact our health and can create modes of discrimination. So an example of intersectionality would be me as a woman, and then me as an African-American woman, and then me as an African-American woman of a certain age, me as an African-American woman of a certain age living in a certain community. So all of these dimensions of who I am can play in how I am able to access housing, for example, or how I am able to access healthcare, because these different ways in which people are discriminated against. It's not just one thing, it's usually a combination of who you are and how you present can bring those modes of discrimination. So we have to sort of untangle this concept of intersectionality as well, and make sure that we are addressing this in the work that we do. Next slide. And then, when we talk about getting to the root cause of the health disparities that we're seeing in our communities. When we ask, one of the things that we do, sort of quality improvement exercises, when you ask the 5 whys, and if you just keep asking why over and over again, you get to the root cause of the problem, and that's what we want to tackle and address in the work that we do. We don't want to just stay at the surface and come up with Band-Aid solutions or short-term solutions, but we really want to get to what is the root cause, what's driving, what are some of the factors that are driving the outcomes, the poor health outcomes that we see. And we know, and clearly this has been supported by research, that racism undergirds a lot of the health disparities that we see in our communities. And Dr. Kamara Jones and David Wellman have done a lot of work around understanding how racism, historical racism, has created that system of disadvantage for individuals and communities, and has created systems of advantage for other communities. And so absolutely, we are looking at how to become an anti-racist organization, and how do we even address racism, whether intentional or unintentional, in how we do our work at RIDOH, and maybe some of the policies and systems that maybe we've put in place. How do we make sure that they are more reflective and really serving the communities, and how do we have those hard conversations even within in the health department and among our colleagues, so that we can really understand the role of racism in the work that we do and how it has impacted the lives of everyone. Next slide. And also understanding that there are different levels of racism. And so at the micro level, we have that internalized racism and interpersonal racism. And I think, oftentimes we see a lot of examples of interpersonal racism that has happened, over the last couple of years. And often this is sort of where the light gets shined the most, is that sort of those interactions between different groups based on race, and the biases that come with that, where we don't see a whole lot of focus and attention, even though we know that it is there and it exists, is at the macro level. So we have the institutional racism and the structural racism, and both are drivers, again, of much of the health disparities that we are seeing in our communities, and really drivers of historically the outcomes of the conditions in which people of color have had to live in for many decades. And so when we talk about institutional racism, it's that racism that exists within, say, the banking industry. A bank denying loans, and this is still happening even in this day, where banks are denying loans to people of color who have the same, income as, someone who is white. So that would be an example of institutional racism. We see institutional racism happening within our academic community as well. And then structural racism is not just one bank has that practice, but when you have across the industry, this is a well-known practice. That would be an example of structural racism, where the policies and the systems are all working together to create systems of advantage and disadvantage. Next slide. And then just, again, to give a couple of examples of structural racism within housing, things like redlining, which has created, this racial wealth gap between African Americans and whites, the lack of affordable housing and substandard housing, being built in communities, Section 8 housing discrimination. When we talk about incarceration, this concept of mass incarceration that came out of the Reagan era, and that has continued, where we know now that in our prison system, we have more, even though African Americans make up 12 to 13% of the population, they are well overrepresented within our criminal justice system, and the ways that the criminal justice system has been used to incarcerate people of color, and the harsh sentences, et cetera. Definitely some structural issues there. And immigration, we, even during the pandemic, when our essential workers some of whom were from our refugee and immigrant community, had to go to work. And they did not have access to paid sick leave, which drove higher rates of transmission and COVID in some of our workplace environments. And much of that was attributed to the fact that these people were immigrants and they did not have the luxury and access to the same kind of benefits that maybe you and I had to be able to stay home and to work from home. And if we got sick, to be able to take sick leave and still be able to pay our bills. And then structural factors, in environmental exposure, in Rhode Island, in Providence, down by the port of Providence and sort of that Washington Park community, lots of issues going on with asthma, and the work that has been done at RIDOH and by some other agencies to address sort of the environmental injustice that has been put on that community and the poor health outcomes of some of the children, higher rates of asthma at much younger ages, and the burden that's, put on parents to be able to kind of address all of this. So those are some of the structural factors that, just examples of how structural racism, when you think about the people who live in Washington Park, and what they're having to deal with in terms of the environment and what's coming off of the Port of Providence, what's coming off of 95, and how it's impacted that community. And then we have the future health narrative where, the work of the Health Equity Institute, the work across RIDOH, working across all of the EOHHS, Executive Office of Health and Human Services, really this understanding, and especially coming out of COVID, where a lot of these issues and isms were exposed, the way we do our work is we have to, sort of confront some of these root causes that have created these disparities and inequities in our communities. We have to overcome, and address those power imbalances that exist in many of our institutions and housing, in the justice system, in the education system. And then how do we overcome some of the structural oppression that is, again, impacting poor health outcomes in our communities. And the way we are approaching this work is, as I mentioned, is really trying to be more upstream and address the policies, the laws, and the regulations that are creating these conditions versus the work that we have done historically, which has been more downstream, where we've been funded to do programs, asthma programs, diabetes programs, all sorts of programs, which are wonderful, but the impact is minimal compared to when you're doing policy work. Policy work has a much broader impact than programmatic work. So I will stop here because I've been chatting quite a bit, and just see if there are any questions. All right, so hearing none, next slide. So, and then we talked about the political determinants of health. And so in a minute, we're gonna watch a video because we don't want to just talk at you for the entire hour, and we have 20 minutes left, and I think our video is 17 minutes, so I'll talk a little faster. But these are some great books. If you want to read the history of, how racism was codified in public policy. Stop and Frisk talks about mass incarceration, great book by Michelle Alexander. Richard Rothstein, the federal HUD, notorious for the work that they have done to prevent people of color from getting housing and taking advantage of the opportunities to build wealth in their families. And then if you look at the National Labor Relations Act, it's kind of fascinating to see how racism and discrimination, even though this act was supposed to create fairness for all, there's a lot of interesting stories within that act that it did not do what it was intended to do. And it did give advantage to some individuals and not so for others. So I think if Is the next slide the video? Oh, and then just there is a history of redlining in Rhode Island. I know sometimes our northern states sort of pretend that they weren't kind of a part of the history of racism and discrimination in this country. But there is a much of an untold story about, even in Rhode Island, how we contributed to a lot of the inequities that we're seeing in our communities of color.
Are there any specific policies you guys are working on, like right now? I'm sure you are. I'm just wondering.
So class, culturally enlisted. We're doing a lot of work around class and really trying to tie class to the civil rights, because class in and of itself doesn't have any enforcement teeth. It's like, we have these wonderful standards and we want you to follow them and we're recommending that you do X, Y, and Z, but we can't enforce. When there's non-compliance, there's no enforcement. But we can enforce it if we tie it to our civil rights compliance. And so we're trying to work with the Attorney General's office and the Office of Civil Rights to say, listen, we have this mandate. It was a huge issue during the pandemic, right? And we can't continue to have providers tell families, well, you can have your daughter, your son, or somebody else translate for you, et cetera. So we're doing a lot of work around class. Adeline is leading a lot of that work. We're also looking at ADA compliance, because that was another issue that came up during the pandemic. And so how can we have stronger policies around, access for those with other abilities. And then we also hired a policy director, which Lauren has been 6 months into his job, and Lauren is on fire. And he is, wherever there is a corner where there could be some policy change, he is working with many of our programs to do that. So we feel that we finally have the staff support to be able to kind of spend time looking into these issues. And it is also a priority within the Executive Office of Health and Human Services. All right, so we are going to play this video for you. We may not have time for discussion, but this is, we did a lot of health equity trainings during the pandemic with staff, and this is a video that we had shared just so that people can understand sort of the historical roots of inequity. And it's a powerful video. Hope you guys enjoy it, and we may have time to take, maybe 1 or 2 questions or have some small dialogue, but Adeline will pull it up and let you guys check it out.
In the middle of the 20th century, the city of St. Louis, Missouri, and the United States federal government condemned and demolished the neighborhoods in downtown St. Louis where African Americans lived, displacing thousands. They built the Gateway Arch. They built a university, interstate highways, hospitals, and middle-class housing that was unaffordable to the former African American residents. Those who were displaced then relocated to the few other places available, converting inner ring suburbs like Ferguson into new segregated enclaves. We have been led to believe that racial segregation in housing was de facto segregation, by accident or the result of private prejudices. Yes, private prejudice clearly contributed to segregation, but by itself it could not have segregated the country without the intention of the federal government to segregate neighborhoods throughout the nation. If, however, we understand the accurate history, the history that was once well known but we've all now forgotten, that racially segregated patterns in every metropolitan area like St. Louis were created by de jure segregation, racially explicit policy on the part of federal, state, and local governments designed to segregate metropolitan areas, then we can understand that we have an unconstitutional residential landscape. And if it's unconstitutional, then we have an obligation to remedy it. The federal government in the New Deal of the Roosevelt administration of the 1930s pursued policies in the mid-20th century that segregated metropolitan areas. One important policy was the first civilian public housing program, which frequently demolished integrated neighborhoods in order to create segregated public housing. In the late 1930s, another New Deal program, the United States Housing Authority, was adopted. The very first projects built under the United States Housing Authority authorization were in Austin, Texas, because the most aggressive proponent of public housing at that time was the congressman from Austin, Lyndon Baines Johnson. And Johnson got the United States Housing Authority to put its first projects in Austin, separate projects for whites, for African Americans, and the project for Hispanics. The project for African Americans was placed in a location that the city plan of Austin had designated as a ghetto for African Americans. The United States Housing Authority and the local Austin Housing Authority demolished something called Emancipation Park, which was a celebrations location for the abolition of slavery. The design was to move all African Americans in the city of Austin into this community, whether in public housing or in private housing. The city of Austin then began to close schools for African Americans elsewhere in the city, and close libraries and other public facilities to force African Americans to move to the east side. Another program that the federal government pursued to enforce segregation was the work of the Federal Housing Administration, the FHA, which subsidized the development of suburbs like Levittown, New York, on condition that they only be sold to white families and that the homes in those suburbs had deeds that prohibited resale to African Americans. The Federal Housing Administration's underwriting manual said that inharmonious racial groups should not be permitted to live in the same communities, meaning that loans to African Americans could not be insured. Government at all levels throughout the nation were involved in promoting and enforcing the restrictive deeds in homes and places like Levittown, and judges enforced the view that these deeds did not violate the Constitution because they were private agreements. Although white middle-class families that moved into suburbs like Levittown could buy property with no down payments if they were veterans and low-interest mortgages, middle-class African Americans had to make substantial down payments and get uninsured mortgages with higher interest rates. In many, if not most cases, African Americans could not get mortgages at all because the federal government would not insure them. As a result, they bought their homes on contract, like an installment plan where they accumulated no equity and could be evicted from their homes in the event of a single missed payment. Thus, contract buyers do not have the option of leaving a declining neighborhood before their properties were paid for in full. If they did, they would lose everything they'd invested in that property to date. The term redlining comes from the federal government's creation of maps of urban areas nationwide. And those maps were color-coded to indicate where it was safe to insure mortgages. Anywhere African Americans lived, even places where African Americans lived nearby, were colored red to indicate to appraisers that these neighborhoods were too risky for the FHA to insure. The FHA's justification was that if African Americans bought homes in white neighborhoods, or even if they bought homes near those neighborhoods, the property values of the homes they were insuring, the white homes they were insuring, would decline, and therefore their loans would be at risk. In 1940, for example, a Detroit builder was denied FHA insurance for a project that was near an African American neighborhood. He then constructed a half-mile concrete wall, 6 feet high and a foot thick, separating the two neighborhoods, and then the FHA approved the loan. In the 3 decades during which it administered this policy, however, the agency never provided or obtained evidence to support its claim that integration undermined property values. In fact, often racial integration caused property values to increase because African Americans' housing supply was so restricted and they had so many fewer choices. If African Americans had access to housing throughout metropolitan areas, supply and demand balances would have kept their rents and home prices at reasonable levels. Without access, landlords and sellers were free to take advantage of the greater demand relative to supply for African American housing. A 1946 National Magazine article described a Chicago building where the landlord had divided a 540-square-foot storefront into 6 cubicles, each housing a family. He had similarly subdivided the second story. Total monthly rent was as great as that generated by a luxury apartment on Chicago's Gold Coast along Lake Michigan. Such exploitation was possible only because public policy denied African Americans opportunities to participate in the city's white housing market. As the federal government concentrated low-income African Americans in single neighborhoods, The homes became overcrowded. Families had to subdivide their homes to make their mortgage payments or their property tax payments. Cities frequently withdrew public services from African American neighborhoods. They collected garbage less frequently. They didn't provide water and sewer services. Polluting industry and toxic waste plants were placed in African American communities in order to protect white neighborhoods from deterioration. The result was that African American neighborhoods frequently turned into slums. White homeowners looked at these places and assumed that slum conditions were characteristics of African Americans, not of government policy that forced this kind of overcrowding. White homeowners then became resistant to African Americans moving into their neighborhoods because they thought they would bring slum conditions with them. Of course, the slums were not created by the people. They were created by the forced concentration, the overcrowding in these neighborhoods. Blockbusting was a scheme in which speculators bought properties in borderline black-white areas, rented or sold them to African American families at above-market prices, persuaded white families residing in these areas that their neighborhoods were turning into African American slums and that values would soon fall precipitously, and then purchased the panicked white homes for less than their worth. Blockbusters' tactics included hiring African American women to push carriages with their babies through white neighborhoods, hiring African American men to drive cars with radios blasting through white neighborhoods, or making random telephone calls to residents of white neighborhoods and asking to speak to someone with a stereotypically African American name, like Johnny May. State licensing agencies that regulated real estate agents could have easily stopped this practice. All they had to do was to lift the license of one or two real estate agents who engaged in these practices, and the practices would have ended. While many de jure segregation policies aimed to keep African Americans far from white residential areas, public officials also shifted African American populations away from downtown business districts so that white commuters, shoppers, and business elites would not be exposed to black people. This was accomplished with slum clearance. One slum clearance tool was the construction of a federal interstate highway system. In many cases, state and local governments, with federal acquiescence, designed interstate highway routes to destroy urban African American communities. In the 1950s, there was a white middle-class neighborhood in Los Angeles that wealthy African Americans began to move into. It was called Sugar Hill. The first thing that happened was that the neighborhood association got together and tried to buy out the African American families who were moving in, offering them more money than the African Americans had paid in order to get them out of the neighborhood. When that didn't work, white homeowners tried to enforce a legal agreement prohibiting them from living in the neighborhood. And when that didn't work, the city council then decided it would be an African American neighborhood. It rezoned it for multiple family housing. It eventually became a slum. And then the Santa Monica Freeway was built to clear that slum to destroy the neighborhood. So these policies all worked together in an unconstitutional fashion to segregate Los Angeles. In 1957, Bill and Daisy Myers were able to purchase a home in Levittown, Pennsylvania, the Levitt Company's second large development. When the mail carrier discovered that he was delivering mail to an African-American family, he let everyone in the neighborhood know, and as many as 600 white demonstrators soon showed up in front of the Myers' house, pelting the family and their home with rocks. Law enforcement stood by as this happened. For 2 months, rocks were thrown, crosses were burned, the Ku Klux Klan symbol was painted on the wall next door. Some policemen stood with the mob, joking and encouraging its participants. One sergeant was actually demoted to patrolman because he objected to orders he had been given not to interfere with the rioters. In 1951, World War II veteran Harvey Clark, his wife Janetta, and 2 small children rented an apartment in all-white Cicero, a suburb of Chicago. When the Clarks refused to leave, a mob of 4,000 rioted, raiding the apartment, destroying the fixtures, and throwing the family's belongings out the window onto the lawn where they were set ablaze. Time magazine reported that the police officers present, quote, acted like ushers politely handling the overflow at a football stadium, unquote. The only people that the grand jury indicted were Harvey Clark, his real estate agent, his NAACP attorney, and the white landlady who rented the apartment to him, as well as her attorney, on charges of inciting a riot and conspiring to lower property values. Stories like this were commonplace, and state-sponsored violence was a means, along with many others, by which all levels of government maintained segregation. Today, African-American incomes are about 60% of white incomes. But African-American wealth is about 10% of white wealth. Most middle-class families in this country gain their wealth from the equity they have in their homes. So this enormous difference between a 60% income ratio and a 10% wealth ratio is almost entirely attributable to federal housing policy implemented through the 20th century. African-American families that were prohibited from buying homes in the suburbs in the 1940s and 50s, and even into the 60s by the Federal Housing Administration, gained none of the equity appreciation that whites gained. Across the country in new developments, these homes in the late 1940s and 1950s sold for about twice national median income. They were affordable to working-class families with an FHA or VA mortgage. African Americans were equally able to afford those homes as whites, but were prohibited from buying them. Today, those homes sell for $300,000 to $400,000 at the minimum, 6 to 8 times national median income. The white families sent their children to college with the wealth they gained from appreciating home equity. They were able to take care of their parents in old age and not depend on their children. They were able to bequeath wealth to their children. None of those advantages accrued to African Americans, who for the most part were prohibited from buying homes in those suburbs. So in 1968, we passed the Fair Housing Act that said, in effect, okay, African Americans, you're now free to buy homes in the suburbs that had been forbidden. But it's an empty promise, because those homes are no longer affordable to the families whose parents or grandparents could have afforded them when whites were buying into those suburbs and gaining the equity and wealth that followed from their purchases. Consider children who come from families where they're economically stressed, or in poor health because they have no access to good health care, or because they live in polluted environments. When they do come to school, for example, they may suffer from asthma because of that pollution and are drowsy from being awake at night, wheezing. They cannot then typically achieve at levels of children who come to school well rested. When you concentrate children like that in single classrooms, it's impossible for teachers to develop the kind of outcomes that they can in middle-class children who come to school healthy, unstressed, and able to pay attention to schooling. What economists know is that African American children from low-income families who grow up in segregated neighborhoods are less likely as adults to move into the middle class than are African American children whose families have the same low incomes, but who live in integrated neighborhoods. So segregation itself impedes intergenerational mobility and perpetuates, rigidifies the inequality that we experience. Another thing that social psychologists have discovered is that decision-making is hampered when you don't have diverse decision-making groups. These psychologists have done experiments where they put people together to solve problems in both diverse groups and in segregated groups. And the diverse groups are much better able to solve problems because they challenge assumptions much more than the segregated groups do. So segregation impedes our political and economic success. We have 3 provisions in the federal Constitution that prohibit the kinds of actions that federal, state, and local governments pursued to create residential segregation. One is the 5th Amendment, which requires the federal government to treat all citizens fairly. Another is the 14th Amendment that requires state and local governments not only to treat citizens fairly, but to treat them equally. And then the 13th Amendment, which abolished slavery, also requires that we banish the effects of slavery, which Congress long ago determined was any form of second-class citizenship. So in fact, the prohibition on African Americans to purchase homes in federally subsidized white communities or the segregation of public housing created a form of second-class citizenship, which was a violation of the 13th Amendment. We cannot reverse de jure segregation mainly with lawsuits. We must also build a national political consensus leading to legislation, a challenging but not impossible task. Our focus now should be to develop policies that promote an integrated society, understanding it will be impossible to fully untangle the web of unconstitutional inequality that we've woven. To begin, we should first contemplate what we have collectively done and, on behalf of our government, accept responsibility to fix it.
All right. I think I've seen this video at least 30 times, and every time I see it, it just gives me the chills. So we want to be respectful of time. It's 10:02, and we're hoping to have a little bit of time to just kind of chat and get reactions. But I hope, just want you all to kind of reflect on that a little bit. That video is available on YouTube if you want to go back and watch it. And then Richard Rothstein also has, the great book, The Color of Law. And he's done a lot of speaking on this topic as well. So, again, this just sort of gives an example of sort of the historical perspective of racism and how many of the inequities and health disparities that we're seeing now, are not rooted in here and today, but they do have a history as to how we got here. So I don't know if anybody has any quick questions, but again, I want to be respectful of time as well. All right. Are you guys still with us? Give me a thumbs up.
Thank you so much.
Well, thank you, Jennifer, for allowing us to chat with the group. Happy to come back if you have any more scholars that might be interested in learning more about the work, and invite you all, if you have any questions or interested in learning more about what we're doing at the Health Equity Institute, you can reach out to myself or Adeline Bailey, and we'd be more than happy to chat with you.
Great. Thank you both so much. This was a great presentation.
Thank you, and all have a good week.
You as well. Bye-bye.
Bye-bye.
Thank you. Bye.